welcome everyone. Thank you so much for joining us today to talk about adults who have experienced or do experience symptoms of clubfoot. My name is Miranda. I'm an external STEP supporter, working with them to do research consultancy. And our panel today for our webinar consists of a clinical expert and 3 adults who have lived experience. We are really grateful there were so many questions came in. Many of them were very specific and they really showed how wide the range of people who have been affected by this condition are. So we're not going to be able to answer every question today and not specific cases. And we appreciate that our panelists do not cover the whole spectrum of scenarios, experiences, age groups, etc. But we hope you can see some common ground. This is part of a project to ensure that STEPs have more resources for adults. So all the questions you've already sent in or any questions that are straggling will be sent over to STEPs for them to look through and hopefully get some answers out in the near future. And STEPs is there to support you. So please do go to the website, email, or use the helpline with any questions that you have. But I'm really just here to open it up and to chair and to make sure we stay on time. So I'm going to start handing over to each of you to introduce yourselves. So if I hand over to Nat first.
My name is Nat Pahiar. I'm a consultant podiatric surgeon, but also honorary professor in Department of Sport and Exercise Medicine, which is where my expertise lies. But in my initial training, I did see a lot of club feet. And I think Gary is a prime example of a patient that I would have seen.
So Gary?
Sure, happy to. Yeah, so hi everyone. So I'm Gary Bamforth. I was born with a clubfoot in my right leg. So I've had 4 corrective surgeries as a child, including the Dillwyn-Evans procedure to straighten my foot out. I've had some problems with my foot in later life, but have found a way to manage my condition through sport and specifically cycling. So very happy to be here today and happy to share my experiences, which I hope may be useful. Thanks.
And Harriet?
Hi everyone. Yeah, I'm Harriet Garfield. I was born with club feet in both my feet, and I had 8 corrective surgeries on each foot between the ages of 0 and 3. I feel like my mum really ought to be here really to talk about her experience because I'm not completely aware of everything that happened, but I hope that I can share my experience as an adult and it's useful for you.
Okay. And Tom?
Hi, I'm Tom Heenan. I also had club feet when I was born. I had 4 operations, I think 3 on one foot, 1 on the other. And I'm probably rather lucky in that I haven't had specific club feet problems into adulthood. I did have some other issues around back problems for a number of years, and which I imagine my feet didn't help, although they weren't the root cause. And I think that a lot of the things I found to help me with the back problems actually relate to a lot of the questions that I'd seen come through. So hopefully it can be helpful, if rather tangential, for some people.
Lovely. Thank you so much. I'm going to jump then straight into the questions, and our first one is about symptoms. So STEPS receives a lot of questions about identifying adult symptoms related to clubfoot, including if mild pains in the ankles and calves are always a sign that clubfoot is the cause, as well as those more extreme symptoms and what those might look like. So for the panel, what symptoms should people be looking out for, and what symptoms have you all experienced? Do you relate them directly to clubfoot? So I'm going to hand over to Nat first for this one.
I suppose the main symptom is pain, and pain can vary, and it varies with activities and what your lifestyle is. You don't seem to, with adult club feet, you don't tend to get symptoms like paresthesia and numbness, which are nerve related, even though that can possibly produce, could be one of the symptoms because your foot is in a particular position where it could trap a nerve in the inside of your ankle, so medial ankle, so it's a tibialis posterior nerve. Swelling can occur if you got too much degeneration in certain joints. Gary's already mentioned Dillwyn-Evans procedure, which is essentially addressing the lateral aspect in order to make it shorter, where you fuse a couple of joints. And sometimes the joints are fused because they're arthritic, degenerative, and that can cause pain. It's a bit like opening and shutting a door that is rusty hinges. It doesn't open and shut. So immobility can be a problem. Disability, because you can't move joints properly, can affect your walking, your standing. And as Tom already mentioned, there could be a link, mechanical link, to your back and all the way to the neck. Because foot, if you think about it very simplistically, it's an interface between body and ground. And foot, in all human beings, there's a specific gait cycle which starts with heel strike, forefoot loading, and toe off. And it's a very smooth cycle. You blink and you've done it. So if you think about the speed at which the foot functions, it's also important. Then you can think about the clubfoot, which is totally doing the opposite. It's locking all the joints. So you're pivoting not on your heel, in your midfoot, and also in your forefoot. And that has a compensatory mechanism. It compensates in other joints, knee, hip, back, even your gait cycle may change. So you could have gait issues. But I think the fundamental symptom would be pain. And pain would vary between patients and activity. So if you want to take up running, for example, just to quote Gary, when I first saw him, all he wanted to do was kick a football with his two sons, because they're mad football supporters, and they support, I don't think, a very nice club in London, to be honest, Gary. You have to
Awesome.
change your club if you're going to carry on this relationship. Gary, that's all Gary wanted to do, but he couldn't do it. And that was his expectations. So pain and disability were the two issues in his case. Swelling can be a problem, paresthesia, not much, numbness, not much. So I think key factor would be a pain.
And Gary, have you experienced, what symptoms have you experienced other than those that Nat's covered off?
Yeah, no, thanks, Nat. A good summary. So I guess until I came into my 30s, I largely had no problems really with my foot, other than a minor limp, which basically I've always had. So I mean, as up until then, I lived a pretty normal life, right? So played football, right-footed, I snowboarded. I even ran a couple of marathons. So it never stopped me doing anything that I wanted to do. What I did find though, as I did sort of hit my 30s, is I used to get a clicking in my ankle joint. It was almost a tension, and then I was then able to sort of unclick it to kind of release the tension, right? So this was maybe like a once a day thing. Then that I then was unable to do that anymore. So I was not able to do the clicking, or the unclicking, should I say, which then was replaced by almost dull ache and a pressure in my right ankle. And then I started getting more shooting pains in my foot. I had a snowboarding accident in Switzerland in 2011. Was then basically told that I had severe arthritis in my ankle and that I should stop, or at least the Swiss consultant told me that I should stop all sports and pretty much everything that I enjoyed doing. And what had happened is that over time, my talus bone, which is your biggest, or the second biggest bone at the back of your foot, had collapsed, and there was barely any cartilage left in the joint space. So that then meant that the bones of my foot were no longer able to move together as they should, which was causing the shooting pains that I was getting, as basically, as I understand it, the bones were crunching together. So yeah, across our conversation, I'm happy to expand on that, and obviously what I've found works best to manage things now, because I'm in a much better place. And on your point about the calf, never had any issues with my calf, thankfully, and I guess I'm quite fortunate that I only have this condition in my right leg. Both Harriet and Thomas have obviously mentioned that they have it in both legs. But I do have no doubt that the problems that I have in my foot do relate to the club foot. because my left foot is fine and my left leg is fine.
Lovely. And Harriet, have you got any other symptoms that you've had?
Yeah, thanks, Amanda. Very similar to what Nat was mentioning, really, just that pain going up through the knees, back, hip, and just feeling all generally quite affected by pain. Again, like Gary, have found really effective ways of managing. So I'm very lucky that, having been told I'd never be able to walk, I live actually a completely normal life. And for me, mainly, it's the pain that kind of sits in the joint between the ankle and the foot, the bit where the foot kind of is flexy, that bit in there just feels like a real focal point for the pain. And I get mini fractures, which means that I often wear kind of a moon boot and keep my feet up. But as Gary said as well, it's interesting that we both experienced the same kind of, it crept in as soon as I turned 30, which was only this year. It's only felt like over the last couple of years, I've really had to make some adjustments to Clubfoot, whereas yeah, as a child, I was very lucky. My mum used to give me physio every night, but I was living a very normal life doing lots of sports and things.
And Tom?
Yeah, so I think I'm slightly different in that in my early 20s, I got a series of back injuries playing hockey, playing squash, doing ludicrously simplistic things like reaching for something out of a bottom drawer. And actually, the pain that I was getting was going down my legs from my back, so kind of sciatic type pain that would reach your toes occasionally. But for me, it's obviously always coming from my back, and I don't really have the ankle problem moving up. However, what it was for me, and I think the key difference that I can add into this is it was a tightness through my legs. So tight hamstrings led to tight lower back, exacerbated by tight calves, exacerbated by the one clubfoot symptom that I do kind of have, which is relatively short Achilles. So once I got on a path to sorting out the tightness in my legs, which took me close to 10 years to find properly, because it originally the treatments were all very much kind of manipulative physio treatments that where the effect and the benefit would not hang around for particularly long, and actually through time for even shorter periods of time. It wasn't until I started doing Pilates, stretching, strengthening that I actually got rid of my symptoms, which is why one of the most important things that's on my write-ups that are on the steps pages is all around active rehabilitation as opposed to passive. So yeah, the pain I had was going down, and the first step in sorting that out was when I was kind of introduced to the idea of stretching my legs out, which, to be honest, I do every single day still, and I still feel the benefit every single day of having that flexibility, which, you know, maybe helping with any knock-on clubfoot symptoms, but to be perfectly honest with you, just helps with the fact that I'm now 45 and I'm probably more flexible than a lot of people that I know.
Fabulous. So that leads lovely into the next question, which is really just about where to get support. If someone does have symptoms, who should they turn to for support, and what questions should they be asking? Let's go to Harriet.
So I don't know if this is useful. I feel like the most useful source of support has been myself understanding my own limits and my own boundaries, and understanding the balance between having fun, doing what I want to do, and pain management. So for me, that's been a question of understanding that actually some pain is really worthwhile, and it's okay to not be able to walk the next day if I've been able to do something I really wanted to do the day before. Also, swimming helps, and it's been a godsend for me to find a personal trainer as well, and I see him 4 or 5 times a week. And he's really helped me understand my limits, and also helped me understand that actually I can have some flexibility and movement, and that movement has been absolutely invaluable for me in managing my pain. I understand this is not quite answering your question though, Miranda. I think a source of support, I mean, physio, is that something that in order to introduce new movements and understand how your body is compensating for the pain, because as we've all talked about, we all get pain in other areas of our bodies, don't we, as a result of this. But I think questions to ask, I think, you know, things around what can be changed. Is there anything that can, because obviously pain is, everyone's scale of pain is different, isn't it? So there might be things that I can manage that others can't, and also vice versa. So it's about thinking what is impacting your life so much that actually it needs to change. I think that's the most useful. I realize that's a bit of a fluffy answer, but I really think it's mainly about understanding psychologically how the pain is affecting you, and for what is limiting in your life that will just be different for everybody. I think probably Gary and Tom can give more useful answers here.
Well, I think from my point of view, in terms of finding out, the key for me was when I found a physiotherapist who focused on activity. So a small amount of kind of classic manipulation and loosening of muscles, and then a large amount of actual movement, which mainly at that time was through Pilates, which is feels extremely beneficial to lots of parts of your body, to be honest. So certainly something I would recommend anybody would try. I think it would be interesting to hear from Nat around how people should manage into that if they have more severe symptoms. However, I can tell you that even when I had like searing pain, searing pain down the back of my legs from sitting staring at screens all day, that when I went to the gym and actually did a gym workout, that made me feel better. So it's I think, again, it's something I'd like to hear from Nat that could be useful to people, is around the benefits of activity, even when it feels like your body can't tolerate it.
Do you want to respond to that, Nat?
If I may, I think all three of you are experienced people with your own problems, and collectively you're actually treating yourselves. I think one of the fundamental thing when I see any patient who's got a musculoskeletal problem is, what is your expectation? Where do you want to be? So in Gary's case, he wanted to kick a football with his two sons. In my view, I thought that's an easy one. I can get you there. I've seen Olympians, I've seen lots of elite sportsmen who want to beat their personal best or whatever. So there's always a goal. Nothing, having a goal is good. And I wholeheartedly agree with Tom. I think activity is good, provided you can manage your pain. Now, if you can't manage your pain, there are things we can help you with. To give you steroid into your joints, which is already degenerating. You really want some other substances, and there are many. And one of them is hyaluronic acid, which is normal, naturally occurring substance within the joint. And in arthritic disease, painful joints is diminished. So you can have a dose of that, and you can have as many times as you want. I don't know how many times we injected Gary's ankle and subtalar joint. So there are strategies. There are platelet-rich plasma injections, which also help arthritic joints. The main evidence is in knee, but I've started using it in ankles and also in small joints in the foot, with some benefit. Not every patient would benefit. Then there are shockwave therapies, and there are lots of other therapies you can have to control that pain. So you manage it with Pilates, and that's excellent. What Tom has portrayed is he's got tightness in his calf. So if you look at calf, anatomy of the calf, it's made up of two muscles. There are the muscles in the back of the leg, gastrocnemius soleus. Achilles tendon is the common tendon, attaches on the back of the heel, and it continues wrapping around the heel and becomes plantar fascia, which attaches onto the toes. Now, calf muscle is attached above the knee, and then you got hamstrings crisscrossing and attached below the knee. And this continues. It's what we call a posterior kinetic chain. So if you loosen up that whole of the posterior kinetic chain, you automatically improve your function. in terms of walking, your gait cycle, everything. So even with the most deformed feet, if you carry on improving the function, you can actually continue with all your activity. So in terms of controlling pain, there are many things available. Don't stop at either paracetamol, codeine, or any of those drugs. You don't need to take those potent drugs. You can have things injected into your joints to improve it. One of the key things Gary mentioned was initially you could click it. And what he was clicking was little osteophytes. Little osteophytes are little bony spurs which occur around arthritic joints. And once you click it, you feel better. And in his case, eventually it stopped because the joint was losing its cushioning material, which was the cartilage. And he was bone on bone grinding, which is when you start to get pain. But you can improve that by putting hyaluronic acid in it and being active. I think being active is the most important thing. Never stop at saying, I can't do this because I'm in pain. Manage the pain and do what you want to do. You can get lots of help. There's lots of help. I think getting a biomechanical assessment and gait analysis is a good way forward. Someone who's got proper kits, and there are podiatrists who are trained in musculoskeletal and podiatric sports medicine, and there are a number of clinics all around. If anybody wanted access to any of these clinics, I've got a number of colleagues who do that. And that would be to see if there are any functional or mechanical elements which could be improved to get you pain-free and also being active. Obviously, there are, in terms of pain control, there are pain management people who, if you've got unremitting pain, you can get stronger painkillers and you control the pain. But I would say keep things life simple, control pain, manage pain, and be as active as possible. It's no different advice to someone who has a grossly arthritic joint. You don't have to have clubfoot to get arthritis. And I see a lot of veteran athletes who have that, and they still continue playing and being active as possible. There are interventions. There are surgical decompression surgeries and what have you also available. So there is a lot of support. I think it's seeking the right person. Tom had this physio who he understood Tom's problem. I think sometimes as clinicians, we apply too much evidence and forget what patients need. What is a patient saying what they need? And that's the key, finding that person. And like Gary went to, I don't know how many people before we met, and I introduced him to a lot of other people who wanted to fuse his ankle. Gary didn't want fusion. And he said, I don't want fusion of my ankle. I want to be active. I don't want to be just out of pain. I want to cycle. I want to kick a ball with my sons. And finding that person.
We will talk a bit more about the ankle fusion in a minute. I just wanted to quickly let Gary jump in and throw you the question a little bit. I think some people feel that they're often quickly dismissed. Have you got any specific advice about that, about getting yourself noticed, as it were?
Yeah, look, great question. I mean, if I think back to when I had the accident that I mentioned, and the Swiss guy telling me that it was game over and I should never try anything again. I guess the key learning from that is that I sort of refuse to accept that as a definite position. So I think it is about exploring your options, right? So I came back, I spoke to the NHS, I got a referral, I got introduced to some great people, including that. And basically my attitude was just to understand what are my options here. So like how could I continue to live the life that I wanted to and remain active? And obviously I was just becoming a young dad. How would I be able to sort of run around with my kids, right? So that was always the goal I had in mind. And that then led to a whole range of different things that we tried: physio, steroid, PRP injections, orthotics, painkillers. I lost track of the amount of times that I was in an air boot when we were trying to take the pressure off my ankle. And then eventually I was like, okay, I gave cycling a go, and that really helped. And the point that really struck me is what I think what Tom and Harriet have both said, which is they both feel better after they exercise, and I'm 100% the same. Sometimes I have bad days and I am in pain, but I guarantee if I do an hour on the bike, I feel 10 times better, and my ankle literally feels stronger just from doing that. So yeah, and I would also, in terms of finding the right person or someone that can help you, the best thing about engaging with Nat over the years is he actually treats the patient versus the condition. So through the things that we tried, he helped me find the right solution that works for me. And it sounds like that's the same experience that Tom and Harriet have had to find what works for them. Because I think we've actually all found different solutions, maybe all exercise based, but all different.
Yeah, I think that's really true. Thank you for that. The next question is all about the emotional side and the psychosocial impact. So I am going to give a couple of examples of the questions we've had, but steps have received a lot of questions about the knock-on impact into the rest of a person's life. So one example is a question submitter who has now found themselves housebound, using a wheelchair on a daily basis. And this obviously has knock-on impacts on their social life and their mental health. And we had another who is really worried about their job, as they're finding it harder going into their 40s, and their job involves a lot of walking. So obviously they're very specific scenarios, very different for everyone, but what advice would you all offer? So if I go over to Gary first.
Sure. So, well, I'm very sorry to hear about the troubles that people are facing, or those two individuals are facing, and I guess there's appreciation that we all have different challenges and conditions. So I guess no one case is the same. I mean, I would echo some of those worries and concerns, which I've gone through too. I guess physically, I always am slightly conscious because my right leg is much skinnier than the left one. As I mentioned, when I came into my mid-30s, I was very worried that I wouldn't be able to be a mobile dad, and running around after my kids. I emphasise with the work commute issues. I work in central London. I travel from Surrey every day for about 6 months. I did that in an air boot, trying to help. So I totally understand those concerns. In terms of advice, what has always really worked for me is sort of a mental thing. So I've always used my frustration of the condition and the pain to almost fuel my determination to not give up and try and find solutions. So, I reset my goals. So I had to acknowledge that the days of marathon running and the snowboarding were over, but instead I became more determined that, as Nat has said, I literally just wanted to be able to kick a ball around in the garden with my kids, which we now do like every weekend, right? And then, so since my mid-30s, cycling's really helped. I've really invested in that. I cycle 5 times a week because it's what I found works for me. A few other things would be obvious stuff. Clearly, footwear is key. If you can experiment here and find the most comfortable pair of shoes that works for you, I would encourage that. And then maybe the last thing to say is that I really took advantage of the pandemic. Now, I know none of us want to have a pandemic again, but it did allow me to give my foot a really good rest and almost a reset. So I appreciate that that's not an option for everyone, but if there is an opportunity to get some extended rests before then getting back into a work commute or something like that, then I would heavily recommend that. But I appreciate that's maybe a unique situation.
Tom, what thoughts have you got on the emotional and social aspect?
Well, I just think, and everyone's said it so far, but just don't underestimate how much better you can feel after you've done something physical. And, in terms of ability for everyone to do it, maybe there are challenges getting there, but swimming is something which is accessible to people with all types of difficult conditions. That's something which always helped me, because before I even found all the Pilates stuff, I knew that I felt better after swimming every single time. But it was always an effort to get to the swimming pool in terms of finishing work and getting there, etc. And I appreciate that in this situation, maybe there's more challenges than just the mental desire to do it. But if you start to associate, if I exercise, I'm going to feel better, then that really keeps you going through the process. And something I wrote on my blog was that you can never go from, if you're trying to reset and you feel like you're at a real low, you can't go to lift the heaviest thing you can possibly lift. You can't run the furthest you can possibly run, but you can actually 100% commit to a routine of something, be it some type of stretching, some type of at-home strengthening, and you'll find a way into it. But it's committing to routine that I believe helps solve more things than actually just saying, well, I'm going to go and try and lift the heaviest thing I can twice, and then I'm not going to have any desire to do it after that because I'll probably feel horrible. But if you actually just commit to routine and just build up what you're doing, then you might be surprised what your real limits are.
Fantastic. What would you like to add to that, Harriet?
Just very briefly, Gary and Tom have said what I would have said. But I was very struck by the person who's worried about their job. I would just say, just make sure you speak out your rights within your employment structure. Everyone is different. It might be that you fall under the Disabilities Act, in which case there's the responsibility to make reasonable adjustments and things like that. So just make sure you've done some reading about what you're owed there. And I was also very struck by the person whose mental health is affected by their social life. And I think if you can, just advice-wise, I appreciate it isn't possible for everybody, but just speaking openly with friends about what you're going through and what it all means to you now and how life is so different. You know, it might surprise you what other pain people might be going through. I'm always amazed, you know, everyone's got their story, and it might be that you have some shared experience with that, which might be helpful. Also kind of finding a way of socializing in a different way. I know myself, when my pain sort of limitations changed, I found it really hard to know like whether I'd be able to do anything anymore. And I was very much, you know, you're tempted to be quite catastrophic, and I was quite catastrophic in my thinking. That actually I slowly managed to find a way of kind of making connection and meaning in the things that I find valuable in life in very different ways, and kind of come out the other end now. But I can very much empathize with how difficult that can be. So yeah, I hope that's helpful for that person. That sounds really hard.
And Nat, is there anything you'd like to add to that conversation?
I mean, you guys are amazing, and I think the answers are already there, the three really good examples. But I think dealing with pain and disability and with the psychological and social issues that go with it, sometimes mental issues. I'm going to quote Churchill in this instance: nothing is impossible, and never take for no for an answer. I think whatever you want to do, you have to just find something that will help you. And sometimes you got to do it yourself. Tom did it himself. In fact, all three of you did it yourselves. But you need that self-determination, and you need a goal. But never take no for an answer, and nothing is impossible. You can do it. You can do it.
Brilliant, thank you. We are now going to move on to the question about ankle fusion. So I realise not everyone will have insight on this, but we have received questions on some more specific cases where patients have been recommended ankle fusion in adulthood, but they have seen there's debate around whether this is a good option. So what factors should be considered, and would ankle replacement be an option? Is it linked with the complexity of the foot and ankle position that comes with Clubfoot? So I know, Gary, you have some experience of this decision, so I'm going to hand over to you.
Yeah, sure. Happy to share some thoughts. So, yes, so this was a decision that about 8 years ago I contemplated long and hard. Maybe 6, actually, maybe 6. And obviously, Nat, we spoke a lot about this. So, this is when I was in a lot of pain, and I was getting all of the sort of bone crunching that I've mentioned, the shooting pains daily. So I was in a pretty low place. I was at a crossroads because I was worried about how the rest of my life was going to play out, just having to manage this pain every day. So had a conversation with Nat about it, and he kindly convened a group of ankle fusion specialists for me to meet. And we sort of flashed up my ankle scans and x-rays, so they all had a look. And I think the resounding opinion from them all was that it would make sense for me to have the fusion, given the clinical nature of what the pictures look like. So obviously I spoke to my wife about this. I thought long and hard about the pros and cons, which I think is really important for any treatment you try. And clearly there was appeal in the fusion, because if anyone doesn't know what it is, it's basically fusing all of your bones together. So it would have been immediate pain relief, but for me the cons outweighed everything, and it helped me make my decision, because I was not prepared to give up and have a non-functional ankle joint, given the stage of my life where I was at. As I mentioned, young dads, want to run around with my kids, and I knew if I had the fusion, well, I guess I probably would have been able to do that in some capacity, but not the capacity that I wanted. So, and there probably wouldn't be a way back to do that. So looking back, I think it's probably the best decision I've ever made from a health perspective, because obviously shortly after that, I really invested in exercise and cycling, and found a different way, and haven't really looked back since, to be honest. So yeah, just to repeat, without question, every time I exercise, my ankle feels better. I can do what I wanted to do. Totally agree with Tom when he said commit to the routine. That's exactly what it's about. Maybe just a couple of other reflections would be, it does come down to the individual patient, I think, and not the condition. So that decision paid off for me, and I've found a way to make it work. But I do still have pain, but I've come to live with that, and I know what I can take. But for others, the best option could be the fusion, because I recognize that many people may have more severe conditions than mine, or that may be the best route for them. But my last bit of advice would be to encourage a thorough review and consideration of all the options before going down, the surgery route.
Thank you. Nat, what have you got to say on ankle fusion?
I think Gary's answered most of the things I would say. If you think about clubfoot deformity, and I've got a foot model here. It's called talipes equinovarus. There are 3 different positions. So the ankle drops, Achilles tendon is tight, and then the foot turns. Sorry, you can't see it, and this is not a very flexible foot. But essentially, it's a deformity within 3 planes of the body. So we got the sagittal plane, which divides the body front and back. And then you got, sorry, that's the frontal plane, sagittal plane from right to left, and then axial, which is from top to bottom. So clubfoot is a triplane deformity. Just fusing just one joint doesn't take care of all the other deformity. So like Gary said, it's very much individual. It's very much what the deformity is and what your disability is and how much pain you're in. Fusion of any joint is what we refer to as a salvage operation. In other words, you're just salvaging that joint to make it pain-free. And once it's fused, you can't undo it. There's no way of doing a revision on it. An ankle joint is a very important joint. But I have to say, I work with some excellent foot and ankle surgeons, one in particular, who would not offer you ankle fusion as a first option. It will go down other routes. So in addition to the ankle fusion, you may need other procedures, things like Dilwyn Evans procedure. So Evans procedure is on the outside of your ankle here. You might need some tendon transfer operations. So in other words, you're looking at it more constructing the foot in a better position and function as well, rather than, so it's called elective surgery, reconstructive surgery. Fusing the ankle joint is a good operation for some, where you just want to be out of pain because that's where your pain is coming from. Also, from clinical point of view, when we decide when to have fusion and when not to have fusion, we actually look at X-rays and CT scans and MRI. Now, I am not a proponent of treating the scans, but the patient. But if the talus, I think Gary mentioned it, is this bone sitting between the leg and the foot. It's a very important bone. It's a bone that allows us to walk uphill over uneven terrain because it adapts the foot position according to the terrain. So it moves in 6 different directions. Now, once that gets damaged to a point where it's starting to collapse, it becomes an important decision whether to fuse it now or wait and see. And from clinical point of view and where the evidence is clear, once the talus starts to collapse, you have to have fusion earlier rather than later. Because if the talus collapses completely, then you're fusing these 2 bones to your heel bone. That means your limb becomes much shorter and very dysfunctional. But it's an important decision you need to discuss with multiple professionals, not just one. But on the back of that, you really want to be able to say what your goals are. And I think exercise as medicine is a big thing at the moment in medicine. And if you can exercise to relieve your pain and be as functional as possible and meet all your goals from day to day, that will be the best solution for you. But don't get me wrong, ankle fusion does have a part to play for certain patients, not all. In terms of ankle replacement, I think the technology has moved on. And there are some superb ankle implants, which actually literally restores. The gentleman I work with, can I mention his name? Yeah. His name is Mr. Suresh Chandrasekhar. He's an excellent foot and ankle surgeon and does a lot of ankle work, especially replacement joints. Works out of Homerton Hospital in East London. And he's a good opinion on whether either ankle fusion or replacement surgery would be better. In fact, just a little story. I referred an elderly lady who was very active, had a grossly grade 4 arthritic ankle joint. I thought fusion was the only option because on our MRI scan, her talus was literally lighting up and he was about to collapse. But he offered an ankle replacement. And that lady, 6 months on, is back doing everything she loves doing. And she's in her 80s. Right? So it's someone you need to speak to, the right person. If one person doesn't satisfy your need, then you must move on to another one until you find someone who can help you. But both those operations are good for the right person, the right patient. It's not for all. And you've got to weigh it up. Just because CT scan X-ray looks dreadful, as long as talus is intact, you can actually do without any surgery.
That's really useful, really insightful. So I'm then going to go back to you and ask specifically about the, now I'm going to pronounce this wrong, Elizabeth frame. So that's the external frame with the metal rings around the leg. Have you got any tips for adults about wearing this and looking after the frame?
I think adults, yes, even children, yes. As I said, there are an Elizabeth frame is the one you're talking about, but there are 3 other frames. There's a TSF, there's a TL hex, and they're all designed differently. So TL hex frame, for example, will correct all the abnormality within the leg and the foot. So you can put pins in different parts of the foot and start correcting it. And it's a slow progress. So in terms of management, I think it's a better option than any other surgical management. Certainly in anatomy that is near normal, but still painful and deformed. Once you get to degenerative joint stage, maybe Lazaroff frame may not work, or any of the frames. They are cumbersome to wear, but you do get used to it after a while. It takes a long time. So you've got to take your time getting adjusted to it. And when you do, if someone does that, and again, I work with one of the best guys in the field. Again, I'm going to mention his name, David Goodyear. He's actually a teacher and a trainer in this external fixation frames. Works out of Royal National Orthopedic Hospital. And Lazaroff, in fact, invented this in Russia. He was a Russian surgeon. And the technology took a long time to come to Europe. It wasn't until 1980s that we understood how the mechanism of the frame worked. And it's a very slow learning curve. But now we got many experts, and I would say we are probably leading the world in external fixation. And it is a good operation, as I've already said, but it does require a lot of care. And there are many issues with it, and infection is one of them. Can you imagine having a metal bit stuck to your leg, multiple rods going across the whole of the leg and the foot? You need to keep it clean, but there's a lot of support. There are specialist nurses who will be assigned to anybody who has a frame, along with the whole team. So you're never alone. Things to look out for are infection around the pin. You can get thrombosis in the leg because all of a sudden you're not moving your muscle. Muscle works as a pump, circulates the blood around the leg and back to the heart and back to the leg. So it's a muscle pump, so you lose that. So thrombosis can be a problem. You can get little infections within the skin, phlebitis, blood vessel inflammation, and of course, pain. It can be painful. So, but you get good support. So I don't want to go into it, and there's lots on the website about how to look after an external fixation frame. But you get good support, so you're never alone. And it's an excellent procedure if it's relevant to your deformity, because it corrects the deformity in all the three planes that I was talking about. Plus, you can actually stretch your Achilles tendon out. You can even do tendon lengthening exercise procedures to maintain the foot in a certain position. So it's a very definitive surgery. But again, like most surgical procedures, it's not for all. And if anybody is thinking about or needs advice, Royal National Orthopedic Hospital has a massive department, and there are so many experts there. They'll be happy to help you.
That is fantastic. We'll reiterate that at the end. This is the final question, and so I'm going to pass it round, but do feel free to jump in. And it's really about what your recommendations are for treatment. What's made a difference to you, and how did you find it? I know we've all already touched on this already. So, Tom, let's go over to you.
Sure. Hopefully you can hear me. I've switched to earpods. I'll just say that there was twice that I was told, and this was mainly because of the back issue. I was twice told that I was kind of finished. Once I was basically just discharged from an NHS physio. She said she couldn't help me. And the second time I was actually living in the US at the time, and I was just prescribed stronger and stronger and stronger painkillers as the route out of it, which didn't work in the slightest. And I knew that immediately. I knew it as the doctor was saying it, that this wasn't going to be the solution, because as far as I could see, there was no end in sight. The painkillers and the anti-inflammatories and things can be useful, in my experience, useful for acute short-term problems. But if you are then on them for a long period, especially those ones like anti-inflammatories and just pain maskers, if you like, in my experience, it doesn't get you anywhere. So to reiterate myself, it's just exercise, routine. Honestly, as well, if the exercise or even something like Pilates, if it's boring, just go to a different person, because I've never found exercise boring once it becomes a challenge. And you then set yourself just small things to be better at each week, and then you end up doing things you could never think about. Like I said earlier, that I managed to injure my back picking up something out of the bottom drawer. Now I pick up heavy weights as one part of my weekly routine. So yeah, be prepared to challenge yourself in little steps. Don't get sucked into a negative routine where actually the benefits are shortening, and just kind of believe that there's something better out there, because in general, I think there is.
Fantastic. I think that's really helpful. Harriet, what's your personal insight?
Thanks, Miranda. I think Tom said it beautifully, really. But I would just say keep active, even if it's an absolutely tiny amount, you're moving, and that's going to help a little bit. Committing to a routine, what's really helped me to be accountable with exercise. There's a class waiting for me, and if I don't go, then that means someone else hasn't been able to go. So go, and you'll feel better. And also just to be kind to yourself. There'll be good days and bad days. This is a lifelong situation. This is not, a short-term fix. And with anything, if it wasn't pain, it would be something else that would be good or bad. So just try and have that sort of long-term bird's eye view on how this is going. And I'd say also, don't feel like you have to be labeled as somebody with clubfoot. There's so much more to the person, and you are not, people aren't just seeing your feet and your disability. There's so much more to you. So just embrace that and find ways of being you despite it. So I hope this has been helpful today.
Well, that was lovely. Thank you. Gary?
Thanks. Yeah, I'd agree. I think that was lovely, Harriet, and echo with everything that Tom said. I guess just an observation from this call from me, which I've found personally really enlightening. I guess this hope and positivity. I think there's so many options out there, and I hope this is coming across to the audience. Tom struck a chord around pain management and obviously use of medicine and drugs. Again, hasn't really worked for me. I've found that gels every now and again, the likes of a Voltarol or something like that, help, but I don't think you can rely on them in the long term. So I think I've probably covered a lot, and I'm probably cycling's biggest ambassador. But, that has honestly transformed my foot and my outlook on life, to be honest, given the improvements that I've seen in the last 7-8 years of intense cycling. That may not sound the most exciting to most people, but you can make it exciting. I use Zwift, which is sort of an indoor cycling racing app that you can use and set your indoor bike up to, which is great, and I love it because I'm pretty competitive. And I love riding up big hills and riding fast down them. So I think it's just about, if you can, try and find an exercise that does make you feel good, that does excite you, that does give you some hope and positivity. Obviously, I have sincere thanks to Nat and his counsel to me over the years. We tried a lot of stuff. He recommended swimming. That didn't work for me, nor did physio really, but cycling did. So I think it is about just trying to find that one thing that you can see can start to make a few small improvements for you. And if you're seeing that, latch onto it and then try and build up from there. And I mean, it's a win-win, because if it's helping your foot or your feet, it should then help you mentally as well. And maybe a final reflection would just be that I think I accept that there are good and bad days, but I do have come to realize that it's probably never going to be perfect. But where I'm at now is more than good enough, and I'm content with that through the various things that I now do and that I've tried.
Brilliant. Thank you so much for that. Nat, have you got anything you'd like to add?
Well, amongst Thomas, Harriet, and Gary, there's a theme, isn't it? Physical activity. And if you look at evidence behind physical activity and its benefits, they're huge. Not just in club feet, but in lots of other cancers. And there's good evidence that if you're physically active, you can actually not only have a better quality of life, but you can actually reverse the disease process. I'm not suggesting that you're going to reverse the clubfoot, but you'll have a better quality of life. Always think about clubfoot as a foot deformity. And as I said, foot works in a certain way. You can improve that. There are people who will help you. There are physiotherapists who will help with function, muscle alignments, muscle strength, flexibility, proprioception, balance. There are podiatrists in particular with interest in musculoskeletal and podiatric sports medicine who can do gait analysis and get you to use of orthotics, bracing, footwear. There are some superb modern shoes which can regulate your gait cycle, and that's what it's about. And if you can function better, you not only feel better, but you're also in less pain. Then on the other side, there are non-steroidal, non-morphine-based or any other pain medication, things that are natural, normal to your body. Things like hyaluronic acid, which I already mentioned, platelet-rich plasma can be used. So there's a lot of help. Don't feel you're on your own. And I think through your GP, you can access the right people, both in the NHS and also in the private sector. If it comes to surgery, there are surgical procedures which will help you. So it's never end point is that nothing can be done. And I'll finish with Churchill. Nothing is impossible, and never take no for an answer. That's the key home message, and be as active as you can.
Fantastic. I will give you
I
an
think one thing, what Harriet says is absolutely right. Just because you got clubfoot doesn't mean you're not Harriet. That's nonsense. Ignore those people. They mean nothing. Yeah. So you've got to be positive as well. One thing that excited me with treating Gary was he was so positive. I knew what he wanted, and he kept repeating it. And I said, right, we're going to work on that. We'll get there. And that's the kind of positivity you need. And I think Harriet's right. Clubfoot is not a deformity. There's not something that changes your character. Harriet is Harriet. Thank you all. Amazing stories. Seriously, I'm honored to be part of this webinar. Truly. I thought Gary was unique. He's about the third person I know who I've helped with a similar problem. But Harriet and Tom, amazing. Great.
Thank you, Nat.
Thank you, Miranda.
To meet you.
Thank you.
Nat.
Thank you, everyone.
Thanks. We're really grateful. Steps are really grateful for all your time and all the input you put in before the webinar. I think one of the key messages that's coming over and over again is that you're not alone. And I know, because I've seen the questions that I haven't been able to share yet, that we've had questions from all different sides of the world, and it's often that really lost question. But Steps is here, and Nat has offered, obviously, that the role of the services in the UK, if you're here, is to go and ask questions. And if you're not in that position, for whatever reason, you're in another country or you're not confident, reach out to Steps. We can put you in touch with other people who have had the same experience, or give you some advice, or recommend who you should go and speak to. We can't obviously answer specific treatment options for you, but we can connect you to other people, so you are not alone. Does anyone want to say anything else before we wrap this up?
Just thank you, Miranda, for having us.
Yeah.
It's been great.
Yes,
support.
thank you.
Yeah. Thanks very much, Miranda. Well done.
Thanks,
Yeah, thanks.
Gary. Thanks for roping me in, Gary.
Thank you so much. Appreciate it.